So, like I said, I'm Chirag Patel. So I'm just going to be discussing today, hopefully this should take about 20-25 minutes, on the neurosurgical management of chronic neuropathic pain. I'll explain along the ways. I know we're using some medical terms here, but I will explain what we're talking about. So I'll go through these different topics today with regards to what is chronic pain, how we define it, and what are the different treatment options. Neuromodulation is a new or a relatively new specialization in neurosurgery. I'll explain that as well, and I'll touch briefly on what the referral pathways are, at least for our hospital here and in Wales, but it's more or less similar to how it works in England and in Scotland as well. And then at the end, there's some useful resources which you could access for more information. So first of all, it's what is chronic pain? And pain is our basic sensation, and it's one of the primary sensations that protects us from the environment. So basically, if there's anything hurting us, then the nerves convey the signals to the brain and tells it there's a part of the body is being hurt and there's something causing it, and it makes us move away to stop that pain. So pain in a way is protective, but sometimes that pain can become a nuisance when it continues to persist and becomes more sort of indolent and chronic in nature. So generally, acute pain is something that you get after an injury, if you had a cut or burn, or if you had a fracture, or after any kind of surgical procedure. And generally, you don't expect this to last very long. Most of the time, it's a few days to weeks, maybe a few months, but definitely not longer than 6 months. Chronic pain is generally pain which is persistent. That's there. You'd expect it to last. It lasts 6 months or longer, but generally you're defined or you're said to have chronic pain if you have pain for 3 months out of 6 months in a year. So that would be classed as a chronic pain. And to sort of give a very vague example of how it works, acute pain is, if you can imagine, is like playing on a guitar and just strumming along on the strings and hearing the music. Whereas chronic pain is a guitar which is connected to an amplifier. And you can imagine the sort of music you get from that. So the amplifier in this instance is your brain. So chronic pain is basically amplified by our brain eventually, and that's why it becomes so severe and intense and then affects our day-to-day living. What is neuropathic pain? This is generally pain that arises from nerves, and especially due to any form of nerve injury. And this could take any place. It could be either some sort of disease process, either an infection, inflammation, cancers, sort of MS, and even after surgery as well. So any pain that is due to nerve injury is called neuropathic pain, and generally these are the ones which tend to persist and become chronic pain. It is very much more common than we all think, and you'd see, at least in the Europe, chronic pain tends to affect almost 1 in 5 adults. And generally, looking at the incidence in the UK, they say almost a third of people in the UK would be suffering from chronic pain. And it is a big burden to us. It affects our daily routines. It stops us from doing things that we routinely do, affects our daily tasks, and especially sleeping. If you can't sleep well, then at the end of the day, you wake up with more pain eventually. And because of the nature of pain, it's difficult to treat this with just oral medication. And a lot of times you'd see, excuse me, almost half of patients come back to and tell you that when they're having chronic pain, in spite of being on multiple medication, trying different stronger painkillers, the pain is still there. I mentioned this, chronic pain. As I mentioned, this chronic pain is pain that persists over 6 months, beyond 6 months. So generally, if any time of the year, if you're suffering from pain for more than 3 months out of 6 months, then you're classed to have chronic pain. And then, as I mentioned, neuropathic pain is due to nerve injury, and this could take any form of nerve injury, whether it's surgery, trauma, infection, inflammation, inflammatory conditions like MS. So that anything related to nerve and the pain that's caused by it is called neuropathic pain. And generally, these are the ones which tend to become more chronic in nature. And we touched on about the sort of the how common chronic pain is and how it affects quite a significant amount of the population at any point in time. And the fact that it's difficult to treat this pain because most of the medication you take generally doesn't completely relieve the pain. And you do find over time that the medication that you're on become less effective. You get side effects from taking stronger painkillers. You would look at other ways, and it's always best to look at other ways to manage that pain eventually. So in my practice as a neurosurgeon, and what do I see referred to me in patients with chronic sort of neuropathic pain, that is nerve-related pain. And this is generally what I see in my practice. And the sort of conditions that are highlighted in yellow are the ones which tend to be more responsive to what I'm going to talk about on the neurosurgical aspect of chronic pain. So when you look at different patients that I see, and the commonest are generally the first sort of 3 or 4 of the top on the top there. The 80% of my patients are people who got chronic back and leg pain, and majority of these are just general wear and tear. You get some of the patients have had surgeries on their back, either they've had spinal fusion done or had disc surgery for sciatica, and then in spite of initial relief of pain after surgery, they have recurring pain afterwards. And a lot of that is to do with either nerve damage, which happens sometimes during surgery, or a lot of times it's because of the scar tissue that develops after surgery that contributes to nerve damage afterwards. Complex regional pain syndrome is a big topic in itself. I don't know if there are any people on this this webinar who suffer from that, but it's a very complex condition to explain. But it's something that starts off after a very, very trivial injury and sets off sort of a chain reaction in your central nervous system that results in chronic pain in different parts of the body. Other conditions where I see patients with diabetes who have diabetic neuropathy or diabetes-related nerve damage who end up having pain as a result of that. Then you see patients who had amputations and get amputation pain or post-amputation stump pain or phantom limb pain as well. What is becoming more frequent now and more common now is cancer-related pain. And this is two reasons. One is obviously cancer treatment are improving. Patients are surviving longer after cancer treatment, but then they're left with pain as a result of either from the cancer itself, which has caused damage to nerves, or even sometimes it's a treatment that we give for the cancer, either in the form of radiotherapy or chemotherapy that causes nerve damage and leaves patients with pain as a result. Other brain-related conditions with pain is stroke, post-stroke. If you get a stroke in specific areas of the brain, it can leave you with chronic pain. MS is quite common. They can have both pain and spasticity as well in MS. Spinal cord tumors can cause the same nerve damage, especially if you get benign spinal cord tumors, where patients would have a normal survival after that, but they are left with chronic pain afterwards. And other sort of newer pains that we now treat are patients with abdominal and pelvic pain, especially after cancers. or in pelvis as well in patients with endometriosis who develop pain or pelvic pain after endometriosis treatment. So this is generally the sort of cohort of patients that get referred to my practice. And generally, if you look at most neurosurgeons who do chronic pain treatment, this is sort of the sort of patients they would see in their day-to-day practice. So the general treatment options for chronic pain, especially neuropathic pain, is threefold. So majority of the time we try and stick to non-interventional or non-surgical options in the first instance, and that's what's listed on there. The problem with medication is the risk of over-reliance on medication and side effects that develop, especially with opioids and certain neuropathic pain medication like gabapentin and pregabalin, which over time become less effective and do tend to have a significant side effect if taken for many, many years. And thirdly, the thinking is now changing. So generally now the sort of recommendation that we're getting from the National Institute for Clinical Excellence is not use strong opioids and sort of drugs like gabapentin, fentanyl, all that for treatment of chronic pain. And if you do have to treat it, then limit the use of the medication to the lowest dose possible, and to restrict the use, to limit the use of the drugs for as little time as possible. Some of them you wouldn't give them for more than 6 months. But I see in my practice where patients come being on opioids, morphine, gabapentin, or pregabalin for 10, 15 years, and they're still taking it. And in spite of that, they're not getting much pain relief. The operations or surgical treatment that I've listed on the right-hand side all come under an umbrella of neurosurgical management called neuromodulation. Now I'll explain that in the next slide, but these are sort of the different techniques that we use for management of chronic pain, which doesn't involve destructive surgery, and it doesn't involve having to give any kind of medication to the patient. And if you do, then it is a different way of giving that medication. So what is neuromodulation? So it's two words, it's neuro and modulation. It's quite simple. Neuro is nerve related, anything to do with nerves. It's class and neuro. Modulate is to change, is to alter. So what we're doing is we're altering the activity of the nerve by basically using technology and basically trying to use the language that the nerves are speaking. And we know by studies done where we've implanted electrodes into the nervous system that the way nerves communicate with each other is via a chemical reaction which results in formation of electrical signals, and there's electric signals going up and down the nerve. So the nerve communication is via electrical signals. So if you use the same phenomena to try and alter the activity of the nerve, then you'd hope you'd modulate the problems that nervous activity is causing and try and improve the symptoms. So that's what neuromodulation is, alteration of nerve activity using either electricity or different chemicals that work on the nerve. And the chemicals are usually drugs. We use this different sort of morphine, bupivacaine. Ziconotide is a new drug which is used on that. So although we're using opioids, when you're using it directly on the nerves, you are reducing the amount of the drug that's required significantly, and in some instances almost 1,000-fold. So that's what neuromodulation is. And this is not new. If you look at Roman literature on medicine and the use of different things, this is actually documented in literature, where initially when we couldn't harness electricity or store it, we were aware that using electricity, you can alter the pain that's there. And these are examples where they use electric fish or eels to manage conditions like pain in the foot from gout or chronic headaches. So we were aware that by by using electrical stimulation on nerves, we can alter their function and hopefully help with symptom control. But then over time, obviously, we've become more advanced. We're able to harness electricity. We're able to store electricity. Obviously, we don't use this anymore in neurosurgery, but we sort of use technology a bit to improve that. So the first sort of intervention, and the one that's sort of more effective than the others I'll talk about, is called spinal cord stimulation. So what is spinal cord stimulation? So spinal cord stimulation is basically a device where we implant a device in the spinal cord to help modulate the nerve activity in the spine. Now, this is used for patients generally with pain in the spinal area, so spinal pain or pain in the limb. So you can't, it's not useful if a patient comes and has pain everywhere, but it's more sort of a focused pain in certain parts of the body. So if it's mainly neck pain or arm pain, lower back pain, or sort of pain down the legs. And like I said earlier in when I talked about patients that I see, this is almost 85% of the patients that I see are patients who got chronic back pain as a result of various things, and this is what would be offered to them. So basically, it's almost, you could say, it's like a pacemaker that is implanted into the spine, and it sits outside the spinal cord. You can see in this picture here, the sort of insulated wires which are implanted under the spine, and they send the signals to the spinal cord. And the signals are created by this pacemaker which sits under the skin and sends the signals down the electric wires. The actual pacemaker itself is remote control, so the patient is able to control the device themselves. So the programming is done by nurse specialists, but then patients go away and use the device to try and manage their pain, and with the hope that if that reduces the pain, then you reduce the reliance on medication. So what would you expect to get from a spinal cord stimulation? So generally, as I said, it's effective more for patients with low back and limb pain or neck pain and upper arm pain. And generally, we see this in practice that about 70 to 80% of patients would get for pain. Now, in chronic pain, because we're not able to cure the pain, when we look at managing chronic pain, success in management of chronic pain is based if you're able to reduce the overall intensity of the pain by about 50%. So if, say, for example, the day-to-day pain in a scoring system, say from 1 to 10, 10 being the worst, the pain is 8 out of 10, then if you can reduce the pain down to 4 out of 10, then that would be considered as a success in management of the chronic pain. So you'd expect that by doing that, you'd improve the mobility of the patient, they were able to go back to work, their mood would improve, and in the long run, with help from the local doctors and your pain clinics, you'd consider reduction in your pain medication, especially the opioids and gabapentin. So this is what you'd expect to see from spinal cord stimulation. And if you wanted to look at this, and if you say this, is this something which is suitable for me, then talk to your GPs. I mean, they are becoming more and more aware about different technology and operation that are available for management of chronic pain. Certainly, if you're under a local pain clinic, they would certainly be able to refer you to a local neurosurgeon who can do that. And I also get other referrals from other specialists like spinal surgeons and orthopedic surgeons as well, and rheumatologists. Okay. The other device that we use is called a drug pump. So basically, this is an implantable drug pump that contains drug in. This is what it looks like. So it's a titanium-based pump, and it's got a reservoir inside it which holds the drug, and it's got a catheter connected to it which runs under the skin and is introduced into the spine. So the drug has got a microchip in it which you can program to tell it what to do. So it delivers the drug into the spine, and then because your giving the drug directly into the spinal cord, it's more effective. And also because the drug is not going anywhere into the body, you get less the drug orally. I only use these pumps. One of the common use for it is definitely in MS patients where we use for managing spasticity. But the current recommendation, at least in the UK itself, is restricted to using this only in patients with cancer. So we're not able to use these pumps in management of non-cancer pain. So with a patient with cancers, this is what we use now to try and manage pain, especially by putting morphine in there and delivering the morphine directly. So if you look at the dosing that is given through the pump, if say, for example, the patient was on 100 or 150 milligrams of morphine per day, by giving the pump, you can reduce that dosing to almost 1 to 2 milligrams a day. So that's a significant reduction in the dose of morphine that you require to manage. By doing that, you effects from it. Okay. The next thing is deep brain stimulation. So this is commonly used for management of chronic pain because the effectiveness is not that great. So generally, you use this if all other therapies have failed. And what it involves is an implantation of an electrode, similar to spinal cord stimulation, where the electrode is implanted. And the electrode is implanted into the brain in certain specific and manage the pain. And this is the wires are connected to a pacemaker which sits under the skin just below the collarbone, like cardiac pacemakers, and the signals go down the wires to the brain. The use is mainly to patients who got stroke-related pain or facial pain, but the evidence out there to demonstrate the effectiveness of this device is not great. There's not much out there to tell us how successful this is. So success rate is definitely low. So the uptake at the moment, at least in the UK, is not as much as you see. But obviously, this does involve having a brain operation. So you risk of having a brain operation. So there are risks of sort of bleeding or seizures when you're introducing these electrodes into the brain. So it's not taken lightly when you do this for patients with chronic pain, but it's not very commonly done, but it's one of the options for management of chronic pain. Chronic headaches and migraines are also one of the condition which is managed with electrical or neuromodulation. And again, you wouldn't offer this firsthand. This is for patients who've been on oral medication and in spite of that are still having severe pain, and then you'd consider this. And this basically involves stimulation. So at the back of the head, there are two important nerves called occipital nerves, which are on either side, just under the skin. And it has been shown that by electrically stimulating these nerves, you can manage patients' migraines and headaches. But generally, you'd need to see a team of specialists who are experts in management of headaches and neurosurgeons who are experienced in doing this before it's decided whether the therapy will be suitable for you. Again, the evidence for this procedure isn't much in terms of effectiveness. There isn't much evidence to show how effective it is. The general consensus is that it does give some relief of pain, but it's not a cure for the chronic migraine or cluster headaches. One of the other things which we also use is peripheral nerve stimulation. So this is basically a needle. So you can see the electrodes, they look like this here. And these are needle electrodes. So these are for patients who got specific, if there's a single nerve in the body which is causing the pain, then we can stimulate this electrically. So it's an outpatient procedure that we do, and it's basically given for a period of about 25-30 minutes, and you'd see that patient get some degree of pain relief, which can last up to about 2 to 3 months. But it does need repetition, so you can't it's not a long-lasting treatment, but because it's less invasive, it doesn't need an operation, and it can be done in an outpatient setting. It's quite useful to do this in patients who are not fit for surgery, or if it's a very specific type of pain affecting a single nerve itself. And just in the bottom picture there, you can see a horse being treated, and it's actually been used in. So when you see horses who have, it's called the shaking head syndrome. So they shake their heads all the time, and sometimes they can do that so violently that it throws the rider off. So the theory is that they do that because of facial pain and headaches, and especially horses get that as well. They get facial pain and headaches. So this is actually proven that when they had this treatment, it stops them shaking their heads. So yeah, it has been tried and tested on horses and then used on humans after that. So there you go. I mentioned earlier about the pathway for referral, and this is how it generally works, especially for the chronic pain service in Wales. But it's not very different for the rest of the UK as well. So you'd see patients generally being seen in chronic pain clinics who get referred into a centralized sort of tertiary complex pain clinic, which consists of a big team of sort of rehab neurologists, occupational therapists, physiotherapists, a neuropsychologist, and then a neurosurgeon. And then we decide based on the symptoms and whether or not the patients are suitable for a type of therapy, and then they go on to have that treatment. So this is sort of the referral pathway. But just because the patients have had a device implanted doesn't mean that they stop their relationship with their chronic pain clinic. You still need to carry on following up patients in the chronic pain clinic, because once you've done the surgery or implanted a device, there's still the matter of working on reducing the sort of list of oral medication that the patients are on. So that's where the chronic pain clinic and GP surgeries come in, is that once the patients are getting good relief of their symptoms, then you start working on reducing the medication. Because you just can't stop everything suddenly. It's quite well known that especially if you've been on strong painkillers, opioids or gabapentin and pregabalin for chronic pain for a long time, and if you do stop it suddenly, your pain will get significantly worse. So it has to be gradually titrated down and to stop it gradually. So that's where the role is for the sort of follow up back into the chronic pain clinic once patients have had their devices implanted. So this is how the pathway works for us, but generally that's similar to a lot of centers around the country. This is probably my last slide. This is some useful resources. There's a QR code there as well you can scan. So I'll put that in there because there's a lot of information out there with use of different implantable devices for managing chronic pain. And it is a big industry as well, and these devices are not cheap by anywhere. They do cost a lot. So as you can understand that there's probably a lot of misinformation as well out there. So these are sort of useful resources. Some of them are from the British Pain Society as well. This is a website called controlyourpain.co.uk, which explains a little bit of detail, and there's some patient stories there as well in there with regards to use of spinal cord stimulation for management of chronic pain. So in your free time, have a look at this. The e-tool is more for healthcare teams where they can access this. It's a free website which they can use. So if say you're seeing a GP who's not sure whether or not you'd be a suitable candidate for neuromodulation, then they can access this website and put the patient details in and the symptoms, and then it would come up with an answer about whether or not the patient will be suitable for referral to a chronic pain clinic for that. So these are some useful resources to look at.